That is the city of Auckland. That's why I'm practicing. I titled the talk. It's different now from what I told you. Reflections on the systems, women's health challenges for patients, staff, and students. Because we all health system is not doctors, it's not nurses, it's not midwives, it's also the patients. So they're also experiencing the health system that we are peddling. Um, that should be top one. It's fine, otherwise I can just go.
Wait. Pushing. Amy, how are you doing?
Oh, okay. Oh, yeah. Fine.
Cool. So I was born and bred in Matladi Necessary and I'm married to Zanella. We've got three children. One is 21, one is 16, one is 14. The first one was born here, the last two were born in New Zealand. So this was their time to learn Siswati because they don't speak much of it now, which is my problem. I should have taught them when they were young. I did my high school in Evelyn Baring. I did my first degree at the University of Swaziland, and I was a school teacher teaching high school mathematics for a while until I went to University of Cape Town for medical school training. During my medical school training, I was telling Dr. O that I was coming to Mbabane government and also RFM for the practicals that we used to do. Do you guys still do that? Do the medical students still come around? Yeah, because we used to be paid for that period by the government. I think they had money at that time. So even if you're there for 6 weeks, you get paid. But I don't know now if they would do that. And then we emigrated in 2005. We went to work, and then subsequently I got into obstetric training and got my fellowship with the College of Australia and New Zealand in 2012. So I've been working basically as a specialist from 2012 in New Zealand. Currently, this is my base hospital called Middlemore Hospital. I do public there, then I do private practice at Ormiston Private Hospital. It's a smaller hospital, but it's where I do my own gynae private. I don't do obstetric private because pregnancy is another thing. You don't sleep. So, um, so just a few things I'll tell about my roles in the department. Obviously, I'm working as a specialist in the department, and we've got a department of quite a number of registrars. So I'm the lead training supervisor for the department. I'll explain a little bit more about that as we go down. And I do a lot of clinical surgical coaching. Much of my coaching has to do with um, laparoscopy, but I still do for my trainees everything from hysteroscopy, from open surgery, laparotomies, and also a lot of laparoscopy stuff. And as a result, I'm in the national coordinators for the whole of New Zealand for all trainees that come into who want to do ONG. We get them through a basic surgical skills course to teach them knot tying, to teach them cutting, to teach them a few little tricks that they need to know. We've now just moved into simulation, laparoscopic simulation, where you have a computer-based software, and then you can have an ectopic cutting it through the little things that are provided. You don't have a lot of tactile feedback, but you can do all the actions. So we do those courses as well in the country for our college. And it's turned out that TLH is laparoscopic hysterectomy. We've had to teach the older specialists who were trained in the 80s, 90s, who don't know laparoscopy. We had to bring them into the new century. So I'm coordinating that for my department. So we've trained about 8 of my department who never had a laparoscopy before. Now they can do a laparoscopic hysterectomy. And then we work with the University of Auckland for the medical students who come for our attachments and provide some lectures and some clinical input for them and do some audits that they do every time they come to the department and assess them. I've already said I've got interest in advanced laparoscopy. This is one of my patients that I did on the 8th of December before I came. I was flying on the 10th, on the 12th. I was doing this case on the 8th. She's 50. She found that she had cancer of the uterus, and the oncologist asked me to remove the uterus, the ovaries, the tubes, and the cervix. So, because the uterus, although it looks big, but it was enough for us to do it laparoscopically. So, we put a few little holes on the tummy, do the procedure, take out the uterus vaginally, and then close everything back with the laparoscope. And then she wakes up, she goes home the next day with just tiny holes. And she's been texting me while I'm here saying, WhatsApping me saying, I'm fine, everything is going well. So that's a standard procedure that we do now in a way that in the department we do about 400 hysterectomies a year. Um, More than two-thirds are now telescopic, laparoscopic. So we're sort of moving slightly over to this. There's still open cases for those who need cancer surgery or massive fibroids. So, just as a comparison, the hospital I'm doing my public practice is called Middlemore, one of the biggest in New Zealand. New Zealand, the biggest city is called Auckland, where we live. We've got three big hospitals. This is one of them. Each one has got a similar capacity, and we do about 8,000 births per year. I think if I'm not wrong, RFM is around 7,000. 7,000. Anyone from RFM? Like in a day, we would have about 26 babies born. So how many babies are born in a day? 20.5. So we're similar. So, but in my unit, there is 20 of the 26 specialists do on call. So I know that you said here there's about three or four, two consultants. Yeah. So for us, it would be 20 do the on call for that similar number of patients, and we would have 10 interns. Those are the PGY1 who just finished medical school and who are coming into to be doctors. And then there's 12 medical officers, those who already are doctors but they haven't decided they want to be orthopedics, neurology, or gynae. They're just working in the department for that time. And then the training registrars, about 30 of them, those are my trainees that I'm supervising for becoming specialists, ONG. Our unit has got 18 labor rooms, so individual, because everything is so individualized. We don't have two women laboring in one room. So we got everyone has got their own room, and there's 18 in the hospital. But there's also about another 10 in the community with small little clinics that are doing some deliveries. There are people who deliver at home still, even there, but it's just a selected few cases. In the labor ward, there will be at least 18 midwives who are on call for that unit. 10 are the hospital ones, and then another 8 are the ones who have been contracted to come if there's an emergency, they come and help. But 10 will be sort of the basic. Is that sort of different from here? It's a bit different. So what are the challenges I've seen? I've been in Babani government for the last 5 weeks. And to be honest, I could have written this in 2002 to 2004 when I was here. Clients book late. The ultrasound is limited. Some don't even do one. They come right in labor. Never done ultrasound. You don't know where the placenta is. You don't know where. Is it one baby, two babies? Is this baby term? Is it baby okay? You just have to go ahead with the labor and deliver the woman. And there's quite a lot of teen pregnancies. I don't know, I'm sort of not sure whether there's an increase. I just found a little bit more than I'm used to. Even I was used to of teen pregnancies. I'm assuming that it's a hangover from COVID because everyone was quite bored around COVID. So there's a lot of there's a lot of babies coming out of that. So and still there's a reasonable number of HIV. I was taken aback because HIV virtually, I mean, it exists in New Zealand, but not at a scale that you would think about it much. So if you have an HIV case, you might get maybe one every 3 months, one patient every 3 months. HIV is looked after by the high risk team because she's got HIV. And what they would do for her is to have her virally suppressed such that the viral load is negative at the time of labor. If it's not, she gets a cesarean section, no question. But generally, everyone gets anxious. They end up doing cesarean anyway, just because the chances of mixing things up are quite, they think they're quite high. So it's very rare. So I would learn from you how to manage HIV because we hardly see any HIV. We would see STIs like gonorrhoeas, chlamydia, other things, but HIV for some reason doesn't like older gametes. I don't know. Um, the issues that come up is that the risk factors don't seem to be picked up easily in the public health unit and antenatal clinics. There are people who come and they've had a cesarean for a big baby, and they already have a big baby now, and no one picked up that there was an issue last time. They're now in labor. So, okay, it sounds silly to get you back into labor when you couldn't do it for a smaller baby with a bigger baby now. Now to sort of decide now maybe we do a cesarean. Say, no, I want to try, but you're just going against the odds. People who've lost babies before, they haven't been investigated. The reason sometimes because they came to a different hospital that time, and then now they're delivering in a different hospital. We don't know what was done because the records in this country are so separate that you can do a patient here, we won't know in Babani what you've done unless you write a letter to us. Our system is such that whatever you've done here, we can already, once you refer them, we can log into the system and find out what was done, what were the blood tests, what was the procedure, which dates, sort of a national system that collects for each patient, because each patient is given a hospital number that you can just punch in and then it gives you anything that's been done on her, whether public or private. Um, I won't talk a lot about the hypertensive disorders. I'll mention them just at the bottom. The mortality rate here is a bit high. It's probably related, not related, it's probably in line with developing countries. I was reading the last China report of 2016. I think the next one is still coming up. It got delayed by COVID, I was told. The 2017 to 20. It's supposed to have been published 2021, but it's not yet because of COVID. But from that 2016, 91 women had died around birth in a period of 3 years. So each year is about 30. That's not just Mama, it's just the whole country of Eswatini. So compared to New Zealand, we would probably have about 10, 10 in a year for a population of 5 million. Um, so if you want to make them to scale, maybe divide the 10 by 5. So we'll be having 2. For every 30 women you lose, we lose 2 women. So which is quite a big disparity because not one woman comes to hospital and wants to go home. The family, no family wants to go home and say, we lost a mother who went to have a baby. No family likes those news, but it happens 30 times in this country. And a lot of the things are based on bleeding. Believe it or not, bleeding is still the major cause of problems in obstetrics. Um, we know that once the placenta comes out, the uterus is supposed to contract. If it doesn't contract, you're supposed to help it out with oxytocin, misoprostol, um, carboprost, or you can take them to theater, do some little tricks, or do a hysterectomy. In New Zealand, they say it's better to remove the womb of a woman, rather explain to the family that you can't have more children than to go to explain that we lost your daughter. It's better to explain you lost the womb than to explain that we lost the daughter. So we don't really take too long to make very serious decisions, because if I lose a mom in labor or birth, it's a massive thing. It's like a whole inquiry is set up, and we have to explain every bit of detail from start to finish, what happened, who did what, and why. And we have to be held before the administrators and explain. So it is a massive thing for us. So if it happens, we actually sometimes the team involved gets given a whole day off the next day to go and just cool down and recollect all the events, because it's a massive thing for us. Abortions are still a big component of death, and hypertension, like preeclampsia, um, and sudden collapse and ectopic pregnancies. That's the order that was given on the last trial of 2016, that the majority would have died from bleeding, some from septic abortion, some from preeclampsia or eclampsia, and some with sudden collapse in the postpartum ward, whether it's because of unrecognized internal bleeding or some cardiomyopathy, postpartum cardiomyopathy, or other reasons that you never know. Okay, keep going. So I'll just give you a little presentation that was given by one of my professor colleagues, Julie Quinlivan. It was given about 2020 at a certain conference. I won't give all of what she was telling us, but I'll just give you some snippets of the issues that we face there and compared to the issues that you also face on this side of the world. So the other teams that were part of the production of the report were Professor Parker, who works in my department. So the main thing is to find out, is there anything that you can do to prevent the death of a mother who's come to have a baby? What are the things that can be avoided? Um, so they found that in New Zealand, if your baby is baby number 4 or higher, you're already at a very high risk of obstetric complications. I'm sure some of you would know what those would be. The main one is the issue of bleeding, because multiparous women are likely to bleed more than primary women. And you find that multiparous women who've had 3, 4, 5, they say, I know it all. I know when I'm in labor. They stay at home, never come to see the hospital until things are late. So it's a very important group. We have a big pandemic of obesity. Obesity is one big issue for us. My daughters were looking at people around and saying, everyone must be very fit here, because they're just saying hardly anyone is obese in this country. Yet in the West, it's like no one even walks now, because everyone is in the bus or the car, and they're getting bigger and bigger and bigger. So if you're doing a cesarean, like I've done a cesarean section with someone who weighs 200 kilograms, so that's like you get lost. You literally get lost, because you can't actually. The theater tables are made for 150 kilos, the normal theater tables that you find in most hospitals. But they've had to bring in new ones to measure, to be able to accommodate this. Even the CT scans, some of them were never made for bigger women. There's a lady that we actually had to take to the zoo. the zoo has got a bigger CT scan, just to be able to get some assessment of what is wrong with her. So obesity, it is actually a very big problem. It's a massive problem. Um, so if you are doing a cesarean for those, some of them, the flap of the abdomen is down here. So you actually can't make the cut underneath. We now cut actually above. We just cut above the fat because when you're cutting above, you go straight into the lower segment of the uterus. So here's some little tricks that we've had to invent because of the issue of obesity. I think I've skipped one. Yeah. I won't talk about the other ones because they are minor in terms of for us. Um, but overall, on the deaths that we get, we also have 32% that we could have avoided. That's New Zealand experience. The contributing factors will always be organizational, personnel, technology, environment, and barriers to care. I will talk a little bit about the first two. Lack of protocols was an issue, believe it or not. It's a first world country, but we still find some policies are either out of date or nobody has reviewed them. And two, poor education and training. Sometimes the staff don't actually know where to find adrenaline in the emergency box. They haven't had a drill enough to know that if there's an emergency, where do we find adrenaline? Where do we find lorazepam? Where do we find things? Those are little things that can actually cost somebody's life. And how many Jews you have to put when you're shopping someone. You need to have those things rehearsed by the team all the time. Poor communication, it happens. Failure or delay in emergency response, it happens. As a result of number 4, they have mandated that because obstetrics is quite an emergency discipline, that all people who are on call for obstetrics have to be residents on site. So if you're on call, you're going to be staying in hospital until your time for the call finishes. And then you hand over to the next team who have to be on site. So the boss, who is the specialist, would be on site, but they put them in the TV room and in the air conditioned room. So just in case you need them, but they can't be staying at home, they need to be here as well. So they have, because of those reasons, that sometimes you leave only the trainees, the registrars to do stuff, and they are scared of calling you because consultants are scary people. I don't know here. But you call them while they're waking up, they're sleeping at night. It's like, what next now? Why can't you just do a cesarean? Why can't you just do that topic? Why do you need me to come? You know? So they're not nice in the nights. During the day, we're very nice people, but at night, we're not very nice. So now they sleep on site. So if you need them, you call them. Poor organization of staff, delay in procedure, access to senior staff. That's one. That's why we now have to sleep in hospital. But it costs them a lot because the civil service to charge the hospital because it's my time they're using up. Personnel factors, I think you can identify with this as well. I'm sure other firm and Babane have got similar issues. Personnel is the skill of the staff might be lacking. Staff that can't recognize what's serious. Uh, we know that in obstetrics, if you've done an obstetric run and you've come out, you don't know anything about postpartum hemorrhage, you don't know anything about eclampsia or preeclampsia. If you cannot regurgitate those two things in your head, you need to go back for that rotation because those are things that will kill women. They will kill women, those two things. Recognize that blood pressure is 180 over 110. It's not because someone is excited to see you. Even if they're walking, they're looking fine, something is not right. Repeat it. If it still comes up the same, you need to say, you are not going home now. We're giving you Adalat to drop it down. We're admitting you. We're checking your baby. If it stabilizes, we're going to induce you or deliver you by cesarean. You need to have those plans and say, this is the plan. You can't just say to her, go and pick up your clothes. Your baby bag's at home. That is bad practice. You just say you are here. If they go, they have to sign and say, I went against the laws. So you should not make it easy for them to go home. That's my point. Communicates very well. Failure to communicate between staff. Um, one of the things that I'm learning as I go is that because of the hierarchy of medicine, that this is professor, this is I'm just nothing at the bottom of the heap. I don't want to bother the professor. I just want to sort things out myself. It is better to be yelled at if they yell, but come and help you. Because if you don't tell them and something goes wrong, they'll yell more. So I think it's better to just have them be part of the solution than struggle on your own, and you end up in big trouble. I'll move on just so I don't spend too much time. Because I do a lot of training, I'll just mention about supervision. If you don't feel competent with the procedure that has to be done, you do not need to be brave and say, I've seen this on YouTube. This is how they do it. It's better to invite the person who knows how to do it, let them see you do it, and then they give you the tick and say, yeah, you know. YouTube is good, but not that good. YouTube has been edited a lot. They will give you the things you need to see, the things that are nice, and the very part of the things that are nice. But real life is not YouTube. Real life is bloody, it's passing, it's a lot of sweat. Real life. Um, I will skip this one, but I just mentioned the first two that late booking happens for us as well, um, and lack of recognition of serious conditions is still at the top of the list. You'll see when I talk about the ones for Eswatini what they also say. Sorry. Oh, you were still taking a picture. Sorry. You got it? Staffing, I'll just quickly mention that protocols are important. Recognize complex things. I'm sure in neurology you've got certain things that are very important. In fact, at the end of the lecture, I'm going to ask the neurologist about pins and needles. The relative just rang me up because when you're a doctor in Swaziland, you should know everything. They got pins and needles on the feet. It's like, I've forgotten what it is for, what the causes are, whether it's a back problem, or it's a brain problem, or it's a vascular problem. So I've not done the general medicine for a long time. But it's good to be able to recognize what is serious for a specialty. If you're a surgical specialty, if you're a medical specialty, if you are in cardiology, if you're in ONG, there's just certain things that you should know. Keep your own little list of things that these I must know. Because when you do your exams, they will go through the common things. Common things compare common, fortunately. For Eswatini, this is what they said in that report. They say there's been a significant increase in maternal mortalities over the decade before 2016, and they found that of the 91 cases reviewed, 85 were avoidable. That is to me quite a significant number of avoidable cases. Um, and when they compare from the avoidable cases, um, there were 51 direct causes in ONG, but 49 of them were avoidable. So the avoidable deaths that were reported, because direct and indirect means that if say you get hit by a car accident while you're pregnant, you're still a maternal mortality death, but it's not a direct obstetric cause. It's like other reasons have caused you to die. But the direct ones, 49 out of the 51 were avoidable causes. They say in the report the main thing is the failure to recognize the seriousness of a patient's condition. I do not know whether that means to me that we as clinicians, from nursing, midwifery, and medical staff, whether we are not teaching enough from our junior colleagues that if this and this happens, you need to cover her. Whether we are so scary that they don't call us until things are right at the bottom. But that's the biggest reason. They say the reason things women die, it's mainly because the people know that this woman is not well, but how unwell this person is, it seems to be a problem. Just this morning in Babani government, a lady came in, was referred from another hospital, had a baby, she had bled, that's her name. She had bled, and they sent her, gave her 2 units and brought her over. And then even in the hospital here, she's still running a pulse of 110, and she's got a blood pressure of 100/50, and she looks pale. And they're giving her 2 units. It's like you can't just keep pouring because if it's not coming out here, something has happened inside. You need to then go and investigate and go do a scan or go to theatre and open up and check what's going on. So sometimes it's those three things that you think she's gonna get better. I know we don't have theatre. I know we don't have blood. I don't know we don't have that. But if you act faster, you prevent her getting more and more seriously sick. Rather getting theatre sorted out is not bleeding. Patient factors as well as that they lack the right information and the patients delay seeking help and they just come whenever they think they're in labor. Admin factors were lack of policy guidelines. If you go to most of the departments we have and ask for a booklet of policies and guidelines for the department, which are up to date, they should be every 3 years updated based on what's currently in the international community's guidelines. Most of our units will fail, and that's something that we can start by just pulling out from other units and say, this is our guideline for bleeding, this is our guideline for blood pressure, our guideline for this. It, it has to be something that is accepted by the unit. The key recommendations from the Eswatini report was that the ministry has to create a supportive environment. I'm sure I could have said that 20 years ago when I was working here. The ministry has to provide adequate staffing. Like you've seen, we've got 20 specialists doing a call for 8,000 women. Here you've got 2 specialists doing the same call. How do you expect the 2 people to work the work of another 18 people? Obviously, there will be fatigue. They will not want to be called for any trivial thing, which I understand because they will be tired. They have to do clinic, they have to do theater, they have to do. It's not possible. It's not possible to do the work of 18 other people if there's 2 of you. You know, maybe tomorrow I should invite the director of health to come. Because I'm going to give the same talking about. The third part is that the facility managers have to give us the ability to function. If the lab doesn't have equipment, the pharmacy doesn't have drugs, how do they expect the whole department or the whole unit to work? For staff, um, they recommended in 2000 in this report that staff that have to deal with emergencies should stay on site. I know that it's probably a pie in the sky for the units, but it may be that because of the seriousness of issues, this is something we need to think about. Let all the people involved in the emergencies stay on site, pay them more for sleeping on site. It's better that then you can save a few mothers in the process. Um, the medical and nursing and midwifery councils should also make sure that the clinical standards are maintained. If a bad outcome comes about, an investigation comes out and say, oh, Dr. So and so didn't show that they have expertise to deal with this. That's what the medical council should be able to say. Can you come down, let's sit down with you. Do you have issues that we need to address? Are there things we need to retrain you for? But if that doesn't happen, then you keep repeating the same mistakes over and over again because there's no no feedback. People are going to guide you and say, no, that's not right, that's not right. I'm about done. So, this is just a little quote I learned. I wrote about pregnant women. Um, I can relate to that. I've never been pregnant, but my wife has got 3 children, but my life has never been the same. I left Swaziland, I was black hair, now I'm gray. So, because I've got 3 children who are demanding a lot. Um, just special thanks to the teams that I've been interacting with in Babane. Um, and I know that a lot of you, when I was working here, they've already probably gone when I was working here. But I used to know quite a lot of people here in the wards, in the theaters, many, many years ago. And the last one, particularly, I just put it on to just say, let's remember that the patients are the reason we're here. Um, they subject themselves to us, to students. They've got everyone poking their knees for reflexes, following their tummies, listening to their hearts, and doing all of that. I think just need to appreciate them and just respect who they are and give them a common decency. Um, Make sure they've got some privacy, some decency, because if they were not there, you probably would not be around because you live because they're there. Thank you. That's the first part of the talk. We can just have a bit of a talk around it, and then there's another shorter version of the some procedures I've been doing there to my life. Anyone has a question on this? Or some clarity or comments?
I have a
Yeah.
question. Thank you for your excellent sharing. I have a question about the ectopic pregnancy.
Yeah.
The prevalence is it also higher than that in New Zealand in terms of ectopic pregnancy?
You mean the prevalence of people who die because of a topic or just in general?
Yeah, the prevalence.
In general.
Or you can also talk about
Um,
as well.
I think we haven't seen a woman die because of a topic in New Zealand for a long time because scans are quite common. Everyone who misses a period wants a scan. Everyone who misses a period just wants a scan. They do the pregnancy test at the pharmacy, then they want a scan. So generally, ectopic pregnancies will be picked up and dealt with pretty early, pretty early. But then the topics themselves are quite common, quite common. We know this, yeah. You know, I think human behavior is the same. Human behavior is the same. So I think especially because contraception also is also an issue, especially younger population. Contraception they don't really like contraception. And especially now our country doesn't have much HIV, so there's not so much. People are not that scared that if I'm in a relationship, sexual relationship, I'm going to get HIV. They know they probably get chlamydia, get gonorrhea, and get treated, but they're not thinking about big major things. So there is quite a bit of topics. There is a town. If you visit New Zealand, I'll tell you where not to go. There's we call it the capital, the STI capital of New Zealand. But it's not my town. Just make sure my girls don't go there. Anyone else? Question? Yes.
Thank you very much, Dr. Mavuso. My question is what your opinion is on the training program that interns carry and where it could be improved. Because the program is fairly new at such a large scale. Before the numbers were quite few, but now the numbers are quite large, but I'm not sure if we are doing a decent job in helping them carry the projects.
That's a big question. I think, to be honest, if I was to make like for like comparison, our interns, um, your interns, let me say this, your interns are doing a lot more work and a lot more responsibility. than our interns. That is, yeah, that's true. I agree. It's because of the shortage of staff, they find themselves needing to make quite serious decisions about patients, and they come and they've got these word rounds, and then they get asked a very difficult question, which is a question that you should be asking registrars who are registrars for that specialty. They're already training to be specialists or chief, but because they're not registrars, so all the hard questions will land on the intern. And there are things that you need to know as an intern, but certain things I think interns here are really having to pick up quite a lot just to fill in the gap of the lack of registrars and medical officers. So it would be, if I were to make it work like it works for us, I would increase the number of medical officers in a unit and let the interns be interns, let them pick up skill slowly as they move through the departments. Give them time and say, this is teaching day, this is, give them the opportunity to learn because the way it works, actually they don't get much of the opportunity to learn. At the end of the day, they get to learn by default. They say they've done something and it went wrong, and they know not to do that. They do something, it goes wrong, not to do that. Eventually, it's harder to find out what is the right thing I can do. How can I actually present my cases properly? Because every time I present, they ask me something weird. What was the indication for the last cesarean? How am I supposed to know that? Because, you don't focus on so many things. So I think it does move things more, it makes things more harder for them. Yet if you were to train them in a systematic fashion, say you are learning the basic emergencies of obstetrics and gynae. What do you do when someone is bleeding, they're early pregnant? Check their cervix, open or closed. How do you treat heavy bleeding outside of pregnancy? Which drugs can you give to slow down bleeding? How do you investigate for somebody who's got amenorrhea? Do you do thyroid function tests? Do you do FSH, LH, androgens and stuff? And those basic things that you just know because they're fresh. Their physiology is fresh. It's much fresher than us. They know a lot more than we do. So just guide them to know the pathology and the clinical practice of the pathology, but they end up getting deep into the pathology and management, and they get criticized for things that they've done. But maybe we should ask ourselves, have we actually taught them the right things first before they get into? Yeah, I think for me, it's just the lack of the buffer of the next layer between them and the specialist. If we had a bigger number of the next layer, then they can, I feel like they can learn better. Those are very hardworking young people, very hardworking. I know they want to achieve things, but it is hard. Yeah, it is hard. That's just my little view on the last few months I'm here, but I'm sure there are many other solutions. What are the solutions? Oh,
I think your input was
yeah, yeah. It's just my outside view. There's probably other answers. Anyone else? I wanted to talk about that one. Intern, no one's an intern yet? Tell us how your life can be made better. Tell us how your life can be made better. What we've done for our interns, another thing is we've said to them as the year starts, go to the department or the specialty they're going to go and tell them, I'm taking leave on this week, on that week, on that week. Have some plans for your life. Say, okay, in this year I'm going to have leave here, leave here, leave here. So that as you move along the departments, it's already planned. It's not like an accident. So, ooh, because you need to have time for yourself. You work hard enough, you need to plan your rest time. If you're going to go shopping in Johannesburg or Dubai, just plan those things ahead of time. You've got enough money to travel, but you need to plan your rest time. Don't wait for your 6 weeks of leave. You get that when you are medical officer. This is your in 10 years, just a trying year. Everyone's going through it. It's not a nice year. At the bottom of the heap, you get all the blame, yet you're working the hardest. Cool. I'm gonna find the other one. Okay,